Hello, my name is Tiffany Shaw-Holmes, and today I'll be talking about stroke. A stroke is caused by a sudden loss of neurological function resulting from focal disturbance of cerebral blood flow due to an ischemia or hemorrhage. So according to the University of Queensland Brain Institute in Australia, close to 50,000 people suffer from stroke annually. Acute care hospitalisation rates continue to show higher admissions among males than females, and most hospitalisations were for people aged 65 and over. Our patient, Mr. Mark, fits both these categories, making him a prime candidate for these high risk factors. The average length of stay for stroke patients in acute hospital care was 7 days. Stroke patients in rehabilitation care have an average length of stay of 24 days. So my presentation will be covering one high priority clinical manifestation of stroke. I will also discuss the pathogenesis causing the clinical manifestation by discussing the case study of Mr. Marks, as well as a high priority nursing intervention to address the clinical manifestation will be provided. As we can see, the pathogenesis of stroke on the mind map is as follows. The interaction of blood flow to cerebral tissue from a thrombus or embolus initiates an ischemic cascade. The mitochondrial production of ATP ceases, resulting in depolarization, causing influx of sodium and calcium. An influx of potassium, passive inflow of water into cells causes cytotoxic edema and destruction of cells in the infarct core. Membrane depolarization also stimulates the release of neurotransmitters, especially glutamate, causing excessive calcium influx into nearby neurons, and ultimately the destruction of cells. Mitochondria break down, releasing toxins and apoptic factors. Injured brain tissue triggers an inflammatory response, which causes a release of inflammatory mediators and causes cell death and edema. Destruction of cells in infarct cause increased necrosis. Ischemic penumbra around core has diminished blood flow but preserves cellular metabolism. Also, an area of necrotic tissue are not able to connect nerve impulses, so functions such as initiating and conveying motor impulses, receiving and interpreting sensory information, and speech control will be interrupted. With this understanding of pathophysiology of stroke, we can now understand that severe right side hemiparesis is caused through injured brain tissue located predominantly in the medial occipital lobe or the inferior and medial temporal lobes. It can also be located in the cerebellum and brainstem, which triggers the inflammatory response, resulting in the release of inflammatory mediators and causes the cell death and edema as discussed in the pathophysiology of stroke. As the left side of the brain tissue is typically damaged in a stroke, it results in the right side of the body being affected, causing the severe right-sided weakness, just like what Mr. Marks has displayed in his clinical manifestations. As Mr. Marks has presented with right side weakness, one of the main nursing interventions should always be to assess airways every 15 minutes. According to New South Wales Health Policy on Stroke, patients with a decreased level of consciousness should be assessed to ensure that they are able to protect their airway. Patients with stroke, especially hemorrhagic stroke, can suffer quick clinical deterioration. Therefore, constant reassessment is critical as Mr. Marks is experiencing severe right-sided weakness. It will need to be noted straight away if his airways stop working and then escalate to avoid aspiration or further complications. This can be achieved by making sure Mr. Marks is positioned in Bella's position with his right side supported with So no pressure is on his right side where he's experienced severe weakness, leaving his airways less strained. Ischemic strokes, less large or involving the brainstem, do not tend to cause immediate problems with airway patency, breathing, or circulation. On the other hand, patients with intercerebral or subarachnoid hemorrhage frequently require intervention for airway protection and ventilation. As Mr. Marks is experiencing clinical manifestations that suggest these areas have been affected during his stroke, these constant airway assessments are detrimental to monitor to avoid deterioration. These assessments should also be documented so any improvement or deterioration can be identified quickly and early to allow for an intervention if needed. Aspiration following stroke, the most clinically symptom of dysphagia, has long been associated with pneumonia, sepsis, and also death. It has been reported that pneumonia was the second most common cause of death during the acute phase of a stroke, with up to 20% of individuals with stroke-related dysphagia dying during the first year post-stroke from aspirated pneumonia. Providing Mr. Marks with constant airway assessment will drastically reduce airway complications from his stroke, possibly reducing his stay in hospital and hopefully reducing his rehabilitation that he will need following his stroke. This in turn will benefit Mr. Marks in numerous areas of his life, including mentally, financially, and physically, which in turn helps reduce the financial impact on the health system. Thank you so much.